much for coming. And to those of you who are watching either in country offices or around the building and haven't come downstairs, welcome to you too. I'm Peter Godfrey Fawcett. Many of you already know me from the Office of the Science panel in UNAIDS. And today's meeting, we're bringing together Professor Roberts, who I'll introduce in a moment, and WHO, Dr. Krug, and shortly Chris from the Essential Medicines program, I think, will be joining us, and we'll introduce them in a minute. And the meeting really came about because Ian has been working on a variety of things over his career. We'll introduce him shortly, but was trying to find out why it was that UNAIDS and WHO, where the next steps should be with a medicine that works and could be useful, both potentially in preventing HIV infections and potentially in saving lives. And so, as a researcher, you get to a stage where you think, well, where do we go next? And he wrote to Michel Sidibe, and Michel Sidibe passed the letter on to myself, and I had some emails backwards and forwards with Ian saying, well, you know, this isn't really mainstream for UNAIDS, but nonetheless it's an area that is of interest. And so we thought we would reach out and talk a little bit to our colleagues in WHO. And then, of course, when we talked to Etienne, we, of course, found quickly that Ian had also been writing to Margaret Chan. And so they were also replying. And so it's been useful to sort of bring us together and see how together we should think about some of the issues being raised. I think the fundamental issue is the issue of how research gets translated into policy and then into practice around the world. And that sort of underlies the topic. And therefore, I hope that the topic's of interest not only to those specifically interested in blood clotting and the ways that tranexamic acid works, but also more generally in the way that evidence is synthesized, in the way that the UN and WHO and departments of health around the world assemble that evidence and decide what should happen as a result and the steps that need to be taken to move from evidence through into practice on the ground. So that's sort of the area that we're going to talk about. The format will be that, first of all, Ian will give an overview and a presentation of the work that he's been doing on tranexamic acid. And then Etienne Krug will give some comments from WHO from the perspective of the Violence and Injury Prevention and Disability Department. And Dr. Weris Surya, who I'm afraid I call Chris because I can never get the name quite right, and I think he doesn't mind that, will give some views from the Essential Medicines program. And then, by all means, I hope we'll have time for some more general discussion along the lines I'm saying. So let me first of all introduce Ian. Ian Roberts, he works at the London School of Hygiene and Tropical Medicine, is a professor of epidemiology there. And so I know him from the time when I was working there as well. And I think that I first became aware of him with the first CRASH trial, which was a very interesting study looking at the use of steroids in patients with head trauma. And I was a clinician at that time, and it was often just assumed that it was a good thing to be giving patients steroids. And it was Ian's work that turned that on its head and made you realize that if you don't produce hard quality evidence, things may be being done that are bad for patients. And so he's been very much in the mainstream of evidence generation, and I think he'll probably explain some of his background in that. He runs the clinical trials unit at the London School of Hygiene and Tropical Medicine, and most recently, or not, he's now working on other things as well, I'm sure, but recently led the CRASH-2 trial, which was a big trial that he'll talk to us about, of tranexamic acid, and it's that we'll start off the presentation with. So let's pass over to Ian, and we will see where we go. And just bear in mind that the camera may have people looking at you as well as those in the room, if you're trying to capture the audience.
Thank you, Peter, for the introduction and thank you to you for coming. It doesn't matter that it's not a big audience. I'm sure all big things start small. So I want to introduce you to this man. Oops-a-daisy. This man. So this man lying on the ground, he's called Surakrant, and Surakrant is a Thai sex worker, and he's HIV positive, and he's in good health because of antiretroviral treatment. And he's had a good night, but it ended up badly. So he made some money, and then he went for a drink, and now he's had a car crash, and he's been hit by a Toyota, and he's bleeding inside. So maybe his kidneys or his spleen has been ruptured, and his hemorrhage inside his body, and he could bleed to death, and he's got quite a high risk of bleeding to death, and 2 million people like him bleed to death, well, not necessarily just like him, but 2 million people bleed to death every year around the world after trauma. So there's a treatment that can reduce his risk of death by about 30%. It's a very cheap treatment, but he probably won't get it. And that's what I wanted to talk about, really, that there are many people around the world, some of them will be HIV positive, some of them will not be HIV positive, who will die for the want of a treatment that costs, just a couple of quid, a couple of francs. So Michel Sidibé had a paper in The Lancet recently where he talked about, in 2010, AIDS was the second most common cause of death from men aged 15 to 49 years. And you can't see this very well, but this is the HIV/AIDS section here. The number there is 10.7. The number in the road traffic injury also is 10.7. So they're joint second leading causes of death. But basically, they're more or less the same people. They're young people. Some people talk about risk-taking. I don't like the term risk-taking. I prefer to think of them as vulnerable. So they're young people, they're at sexual risk, they're at risk of road traffic injury, they're at risk of violence. They're just people, young people. Now, in this particular young person, the problem is hemorrhage, and so the blood is leaking out of his spleen, and this yellow stuff is blood clot. It's called fibrin, but there's an enzyme in the blood that for some reason breaks down this fibrin, even when we're bleeding to death. And we don't need this enzyme. It's called plasmin. We don't need this enzyme when we're bleeding to death. We actually we want to form blood clot, not to have the blood clot cut up into little pieces. Now, this woman is a remarkable woman. She's called Utako Okamoto. I met her in Japan. In this picture, she's in her 30s. When I met her, she's 96. So around about the year I was born, which is some time ago now, she invented a drug that inhibits this enzyme, plasmin. And it was quite remarkable. She was like, this is our husband, this is her daughter. In those days, there was no childcare, so they all went to the laboratory and did the research together. So they're a research family, and they invented a drug called tranexamic acid that was a very potent inhibitor of this enzyme plasmin that makes the blood thin even when you're bleeding, possibly to death. So this is a very effective way to help clotting, and there have been lots and lots of randomized controlled trials of this drug in surgical patients. So in a surgical patient going for surgery, obviously surgery always leads to bleeding, in various amounts. So patients are randomly allocated to have tranexamic acid or not. And in this particular example, they've measured blood loss and the need for blood transfusion. Well, it's quite a highly significant reduction in the need for transfusion with tranexamic acid. It reduces the need for a blood transfusion by about a third. And it's like highly statistically significant. There's lots of zeros after the decimal point. So it's p less than 0.000. So, quite lots of, it's not a fluke. So this is a drug that really reduces bleeding. And that's good. And that should be of interest to UNAIDS as well, because the traditional way all over the world to respond to bleeding is to give a blood transfusion. So when people are bleeding, we give a blood transfusion. We take some blood from somebody else's body and we put it into the body of the person who's bleeding. And that's a risky thing to do. I would much, if I was bleeding anywhere in the world, I would much rather have tranexamic acid than a blood transfusion. Blood transfusion's really dangerous. It's very unevidence-based. I think most blood transfusion does more harm than good, is my own view. There have been randomized trials of blood transfusion comparing people who got more blood versus less blood. And the group that gets less blood always does better so far. So, but nevertheless, all around the world, WHO as well spends a lot of its time and energy encouraging people to either donate blood or finding ways to make sure that the blood they infuse into people is safe. But it's nowhere near as safe as giving tranexamic acid. Tranexamic acid is a much safer solution to the problem of bleeding than blood transfusion. And blood transfusion should interest HIV AIDS advocates because some people acquire HIV through blood transfusion. We did some estimates some time ago. In some parts of sub-Saharan Africa, 1 infection per 1,000 blood units. There's testing, but if you've been to the same hospitals as I have in sub-Saharan Africa, if you will have a blood transfusion, if you'll put your faith in the fact that some laboratory technician got up in the middle of the night and did all the tests properly, and so the blood's safe, then, well, I don't know. I would be a little bit nervous about that. I would prefer not to have blood transfusion. So tranexamic acid is a highly cost-effective way of avoiding transfusion-associated HIV. Transfusion-associated HIV isn't a huge problem in the world, but it is a problem. And actually, it's not really the size of problems that should make us interested in them. It's the what we can do about them that should make us interested in them. We should be interested in problems for which there are highly cost-effective solutions. And this is a highly cost-effective way of reducing transfusion-associated HIV. It's also a highly cost-effective way of reducing hepatitis B virus and hepatitis C virus. So we were interested in whether it's this treatment that we know reduces the risk of bleeding. We know it reduces bleeding. We were interested whether it might reduce the risk of bleeding to death. So we did a big trial. Lots of people all over the world collaborated on this. Etienne was very supportive. WHO supported in principle this study, and that helped a lot. And we were interested in patients who had violence like this. This woman's been stabbed in the stomach. She's bleeding. And these people are involved in a car crash. Thousands of people are involved in car crashes every day. Just talking about the person responsible for trauma care in WHO who's off because she's been involved in a car crash. And she's got health problems resulting from that. So we randomly allocated 20,000 patients to get tranexamic acid or not. 10,000 got tranexamic acid, 10,000 got placebo. We followed the two groups to find out how many people died in both groups, how many people got disabled in both groups, how many people got side effects in both groups. Lovely result, really fantastic. Highly significant reduction in the risk of bleeding to death. 15% reduction in the risk of bleeding to death, but we found that the treatment was highly time sensitive. So that the overall reduction in risk of bleeding to death was 15%, but if you give the treatment early, within 3 hours, it's about 30% reduction in the risk of bleeding to death, which is really good. Highly significant, not a fluke. And it works everywhere. This is a stratified analysis. Now, so what we're looking at is whether this, and this differ from this. And in this stratified analysis, there's no variation by country. So the treatment works everywhere. It works in Africa, in Asia, in Europe. And it's not surprising because there might be superficial differences between us. We might have different shades of skin and slightly different facial features, but we're all the same when it comes to our coagulation. Now, the first people that stood to benefit from this treatment were people in the army. The British Army started using it straight away. They thought it was a very obvious thing to do. And the good thing about the British Army is when the military medicine doctors say you should use it, everybody used it. So there were lots of beneficiaries in the army. The US Army were harder to convince because they were initially a little bit skeptical. I went along to talk to them, and in a meeting in Washington, I photographed this. It looks a bit like UNAIDS, doesn't it? It looks like this. These look like the UNAIDS logo, but it's actually, these are soldiers who died in Iraq. And just so I photographed this in Arlington Cemetery. It just happens to be there's 100 graves on this photograph, and I wanted to show these military general types what a 30% reduction in the risk of death looks like, and it looks like that. So they were understood that. They were a little bit skeptical, so they did their own study in Camp Bastion. They compared soldiers treated with tranexamic acid with soldiers not treated with tranexamic acid. It's not really good science because they weren't randomized. It turned out the soldiers who were treated with tranexamic acid were much more severely injured than those who were not, but even so, they were much less likely to die, much less likely to bleed to death. So then they got interested in this treatment. And in fact, I got a letter from President Obama's doctor to say that he's using tranexamic acid. It's part of his treatment protocol. Presidents of the United States have a very high risk of being shot. 1 in 4 have been shot. There have been 44 presidents and 11 have been shot. So being shot is taken seriously by military medicine. The doctor who looks after President Obama, and he's put tranexamic acid in his treatment protocol. And we estimate that it could save hundreds of thousands, well, tens of thousands, actually over 100,000 lives around the world every year. We estimate something like 120,000 lives could be saved every year. But the thing is, it's really cost effective. You know, it's a highly cost effective way to save a life.
How do you administer it?
It's an injection. It's just a short injection.
It's also risky for...
Intravenous injection.
Yeah, so you need to have clean needles.
Yes, you do need to have clean needles, yeah. So a lot of people have incorporated into their treatment protocols, but these are, you know, high-income countries, you know, Britain, Japan, places like that. It's not where most patients will bleed to death are. They're in, 90% of trauma deaths are in low and middle-income countries. And this is Peter Peart. He used to be the director of UNAIDS, didn't he? So he used to be calling, for everybody to get antiretrovirals, but in this, he's actually calling for everybody who needs it to get tranexamic acid. So he's been very helpful, and we've got lots to learn from the success of UNAIDS in getting antiretrovirals. I mean, a remarkable achievement, to get people, millions of people, to have a treatment that you have to take every day of your life. That's a real something. So you must be able to teach us how to get patients to get a short infusion of a drug once on one day, the day they're potentially bleeding to death. Some of the reasons I think that you get into difficulties is that we get too sort of partisan about this sort of medical tribalism about, diseases and whose disease is bigger than yours. I think this thing, the Global Burden of Disease study, I still think it's probably done more harm than good, in that it just encourages people to advocate for their disease over some other disease. But it doesn't really matter, because it's about patients, really. It's about people and not diseases. Diseases are just labels that doctors use, and it's not really the most important thing. And I was really encouraged that Michel Sidibe seemed to be saying the same thing in a paper in The Lancet. He wrote that the paper was called AIDS is Not Over. He wrote it with Peter Peart from London School of Hygiene. Innovation urgently needed to identify the most cost-effective approaches to HIV in the context of people-centered solutions. So I think, this people-centeredness is really important. It's not people-centered to actually treat people, to give, fight really hard to make sure that people get antiretrovirals every day of their life, and then let them bleed to death if they get in a car crash or if someone stabs them, because they're the same people. They're the same people who are affected by both problems. And today's leadership must develop more people-centered approaches to global health. So both the focus on cost-effectiveness and people-centered encouraged me to write, and that's why I wrote to Michel Sidibe, and that's why I'm grateful to Peter for convening us here. Small but important group, I think. So this is cost-effectiveness. This is some cost-effectiveness data. So one of the best buys of anything in the world, as far as I'm concerned, is insecticide-treated bed nets. If I was talking to the Minister of Health in Malawi and I said, look, if you've got to do anything, from a people-centered solution approach, if you've got to do anything, if you haven't got any money for anything else, do insecticide-treated bed nets. It's really highly cost-effective. But tranexamic acid for trauma patients is almost as cost-effective. Antiretrovirals is very cost-effective, but nowhere near as cost-effective as those other two. So if you have a certain amount of money, and the world has only got a certain amount of money, and you want to actually maximize the reduction in human suffering with that much money, you'll focus first on cost-effective interventions. So you'll focus on all of these, but you certainly won't do that if you haven't already done the other two. So there he is. That's our patient, HIV positive, bleeding to death for the want of a treatment. Now this organisation's done really fantastic things. So I hope that I'm sure that we're going to make sure that patients will not bleed to death for want of this simple treatment, and I hope that UNAIDS will help with that, so we can learn from the lessons of their successes of getting so many people on antiretrovirals. So I think there's one perversity. I shouldn't end with a perversity, but this is, having found that this treatment reduces the risk of bleeding to death in trauma, African doctors say, well, look, why don't we do a trial of the same treatment in postpartum hemorrhage, which kills 100,000 women every year? So we said, okay, after a long time, we said, okay, we'll do a trial of tranexamic acid in postpartum hemorrhage. And we're doing one now. And this is a hospital in Nigeria I was visiting. And so this is the obstetrician here. The problem was the hospital was closed, the hospital was shut. The hospital had run out of money and they'd closed the hospital. And so we went into the hospital, you know, even though it was closed, to check some case notes and so forth. And there was one light on, and there was one little piece of activity in this hospital. And I said to the obstetrician, I said, well, you know, it's not completely closed. There's something going on. And there was a guard, you know, by a door. And he said, yes, that's the PEPFAR clinic. There was one clinic in the hospital that if you were HIV positive and pregnant, you could get treated. So the hospital was closed, but if you were HIV positive and pregnant, you could be treated. I just thought, how strange we are. How can we do such strange things? So all of the people from this community, you know, they could have an obstructed labour. Well, they would die and their baby would die with them. They could have postpartum hemorrhage. They'd bleed to death at the hospital gate. But if they were HIV positive and pregnant, they could go into the hospital because the guard would let them in and they would be treated. That's not people-centred. And so I hope we can be more people-centred. I agree with Michel Sidibe. We need to be more people-centred. And I think tranexamic acid for bleeding trauma patients is people-centred. Thank you.
Thanks, Ian, very much. And I don't know whether we should have, I think we'll keep the discussion, and as it were, what do you think? Should we have a discussion at the end, or other things, other questions that people, maybe while it's fresh, it's perhaps easier to have questions while it's still fresh, if there are things that Ian said that sort of make you want to ask something either about the drug itself or the proposition. And we are linked up to elsewhere, so I'm afraid not only are you going to ask a question, Monique, but you have to come up and be on camera to ask your question. So you just have to come into the sort of middle ground here to be, so that people can see that you're there.
So I have to look that way?
I don't think it...
I can stand here then, perhaps, because then they can see everybody. Interesting presentation. My question was exactly how broad can you use this medicine? Are there any other applications? And the maternal bleeding is certainly perhaps one that can also bring this product more widely used. And but I understand that this trial stopped that you were doing with pregnant women. And the other question is there any research on an application that you wouldn't need to have injections, because perhaps that is even more safer for people, and certainly in low resource areas? Mm. And I'm Monique from UNAIDS.
Thank you, Monique. I don't need this, do I? We've got a trial of the other applications. Our hypothesis, we think it probably works in all forms of bleeding and not just traumatic bleeding. So that's why we're doing a big trial of that treatment in postpartum hemorrhage. We've randomized about 10,000 women so far, and we're going to go for another 10,000 women probably. So we'll get a result from that in a couple of years. Then we're also doing a trial in gastrointestinal bleeding. My big brother, Chris, he bled to death after a gastrointestinal bleed. And I think it's likely that this treatment would reduce the risk of death in gastrointestinal bleeding, but we're doing a big trial of that too. We're randomizing 10,000 patients there. So I think it probably, it works in surgical hemorrhage, in even bleeding into the eye. It probably reduces bleeding from all. But the problem with medicine is it's sort of organized in silos. So even though you show it works in trauma, the obstetricians won't take that as evidence. You have to provide them with evidence in their area, and similarly in gastrointestinal disease, and we're doing a trial of the same treatment in intracranial hemorrhage, both spontaneous and traumatic. So that's the first part of your question. The second part of your question is there any evidence that you could have a non-intravenous way to do it? To start with, our strategy in terms of research strategy is to make sure it works first. And intravenous, in the treatment of a hemorrhage, intravenous has really good advantages because it's much quicker. But if we can show once we're sure it is effective and safe, then we'll try we'll look for better modes of administration. Even topical administration, we've seen from other trials that that's effective. So you don't even have to inject it into the vein. If you see something bleeding, you can just pour it on and it works as well.
Up the top.
Yeah, thanks.
Around the other side. That one.
Oh,
that
yeah.
grey one.
Thanks. Can you? Sorry. Is it working now? Maybe I should do that. Yeah, thank you. That's more practical. So I was just saying thanks very much for answering the question Monique had, because the same question I had. But when do you, I have three questions. So when do you think the results will be available on the maternal postpartum hemorrhage? That's one. The second, what is the likelihood that administration can be done by non-clinicians if it's that simple? And if you're talking about even potentially topical application, is it possible to think about community health workers or other, lay people? And the third thing I wanted to ask you is about, I would expect every president and everybody who can to actually have this in their kit, not just President Obama's doctor. And I'm wondering if you know other presidents that have taken this on, or presidents' doctors that are, running for this.
Okay, so the first question, the postpartum hemorrhage trial will get a result in a couple of years' time, but in trauma we know it's safe and effective. I think you're probably right that if we show it's effective in postpartum hemorrhage, that will be a big stimulus to get it into practice, because lots and lots of people are concerned about maternal death. Why they're not concerned about paternal death, I don't really know. It's a strange thing. I've found it many times that we seem to be very worried about women and not men. Men are quite vulnerable, really. I've got I've got 4 children now, by the way. But I've got a big girl and a big boy, and every talk said people consider my daughter as vulnerable. I always knew my son was more vulnerable. So anyway, I sort of get this idea behind your question that if it's shown to be effective in postpartum hemorrhage, that will be a big stimulus. But it irks me why we're happy to let 100,000 men die unnecessarily each year. So that was the first one. The second one, sorry.
Actually, let me just respond.
Yeah.
Let me just respond real quickly to the paternal part. I fully agree. I think I'm just assuming that it's a given that this would be administered to men in the things you just shown. So I assume that was going on. I think, or would be going on. The issue was about proving the maternal application. So because I assumed the other one was a given.
Yeah.
But I fully agree with you.
especially me, here at UNAIDS, boys and girls, men and women, need to receive the same amount of attention, the same amount of care. So I just wanted to quickly respond to that. But my second question had to do with who would be in a position to administer because if it was decentralization, and the third one was about the presidency.
Okay. I mean, what you take as a given that people will get it, that's a myth, that you can show a treatment's effective, but nobody will get it. I think you can be fairly sure that more than 99% of patients who stand to benefit from receiving this treatment don't. Because, finding that something works is just the first part of getting patient benefit. There's a huge bit of work to be done to get research into practice. Now, UNAIDS are brilliant at that bit of work. They've had some of them, they've had major successes. But, there's an enormous job to be done there. And I don't find very many people interested. It's very there isn't the same interest in trauma death and preventing it as there are in. It's not a very sexy problem in the world. Can non-doctors give it? Definitely, they already are in the UK. In the UK, their paramedics give it in ambulances. So it's not difficult to do. So anybody who can administer an intravenous drug can do it. And I don't know why. I haven't written to all the presidents of the world, but but that's an idea.
It is.
Yeah.
It'd be good. It's good.
If I had their, if I had the time.
Ian, hi. Margaret Peden. I'm from the trauma side of the discussion. I have a two-part question. The first part is around contraindications and complications. I think we've said a lot about how it does work. I just wanted to hear a little bit about when it doesn't work. And then the second part of my question is what methods, beyond getting it in the Lancet and some other papers that I see that you've written, we can advocate to actually get this taken up in countries?
Okay, in terms of side effects, we really didn't find any at all. And that was really interesting because in general, treatments that help clotting increase the risk of unwanted clotting. So if you stop someone bleeding, it might cause clotting side effects like heart attacks and strokes and DVT and pulmonary embolism, but it didn't. In fact, it reduced the risk of heart attacks and strokes. So there was a highly statistically significant reduction in heart attacks and strokes, and a non-significant reduction in DVT and pulmonary embolism. And it seems that it goes like this, that if you get bad bleeding, you get really sick. If you get really sick, you have these nasty thrombotic side effects. If you stop people getting really sick, you stop them having the thrombotic side effects. So it seems to reduce bleeding and unwanted clotting. So it's not a dangerous drug. It doesn't seem to have any major side effects. And in terms of, really, I think getting a paper published in the Lancet, all it does is it's just legitimization for it's a legitimization of, it's just a sort of small hurdle that you've got to get over before a huge bit of work with advocacy and politics and marketing and emotions and all of the things that, I was wandering around in the lobby out there that UNAIDS is very good at. But there's a huge job to be done. Yeah.
Let's, by all means, other questions, put your hand up. But let me just make a couple of questions myself, and then we'll move over to the WHO side before we sort of move from the more specifically HIV side, because I think you raise very interesting comments about the way that we've managed to get people onto antiretroviral drugs, and that's only a part of the HIV response, of course. And I think that HIV has been, without doubt, exceptional, particularly in people of our age. It's been the defining health change. It's the biggest thing. If you look at rates of death in particular demographics, slightly as you shared on your global burden of disease slide, most rates of death, they change gradually over time, and death rates in men might be coming down a little bit, or trauma rates might be going up a little bit, whereas HIV obviously came from 0 and went right up and has now come right down again because of the response. And that's a sort of, why was that? Why has that been? How has HIV been able to be so successful? And that's a really important question. It comes from a sort of maybe a storm. People talk about perfect storms of different things coming together. It clearly comes from a response within the communities directly affected themselves, and not just from the scientists. So it's a ground up approach from the community. It clearly became a political and not just a research event at an early stage in the epidemic. It clearly became that it was to do with global solidarity, and not merely working out the cost of a treatment and the effectiveness. It probably came serendipitously at a good time. The UN General Assembly, the first time they had a general session on health was about HIV. It led to saying we must do something about HIV, and the world has done something about HIV and has put money behind it and has created a global fund and PEPFAR, whereas the UN has also said that non-communicable diseases are a disaster and are killing far more people than HIV kills. And actually the world has done remarkably little about it in terms of how it responds. And maybe that's because of timing and not coming at an optimistic time before the millennium, when people felt that they could do something positive about the world, and HIV perhaps rode that wave like a surfer, whereas the NCDs perhaps got left behind the crest of the wave and didn't get onto it. So I perhaps take issue with your statement that the world only has a certain amount of money. Because the world, of course, it has a certain amount of money, but it doesn't only have a certain amount of money for health. It has money for building motorways or for blowing up people in Afghanistan or whatever it happens to be. And there are choices that get made. And I think that a lot of the AIDS response has been, not all, but a lot of it has been on additional money that has been brought in by political and community and other momentum that has sort of allowed this sort of event to happen. And I think that to look just through the lens of cost efficacy may be a mistake, because it sometimes limits one's sort of ambition in a way, because it's not necessarily stealing from Peter to pay Paul, if that's the right expression, because I think that we should be concentrating on building the larger response. And then, of course, where it fits within UNAIDS, I think that, Michel Sidibe is right, that we're trying to learn some of the lessons from the HIV response and make them more generally applicable across health and development. We're trying to understand, we talk about HIV out of isolation, we talk about integration with other areas of health. We try to get beyond the picture you suggest of a PEPFAR clinic that is only supporting one particular thing, because in general, money put into laboratory services, procurement services, monitoring services have had more widely pervasive benefits than just for the people with HIV. Nonetheless, of course, we come at it with a lens that's focused on HIV and people living with HIV and communities affected by HIV. And that allows us to have a tight focus in prioritization, because otherwise you also come to the danger of an organization trying to be all things to everybody. And I think UNAIDS still sees, I don't dispute the arguments you lay out. I think that there's some challenge to imagine a situation where within 3 hours of falling off your motorbike, you could have somebody giving you an intravenous injection. In many parts of the world, that's at the moment quite hard to imagine in terms of the infrastructure, the organization, the logistics, the sell-by dates, the cold chain. I think it's just as complicated probably as trying to have antiretroviral pills available in the local pharmacy. And we know that despite the fact it's a big success, that getting antiretrovirals down and out the periphery and out to lay workers and task shifting down the line so that it happens nearer to people's home is essential, but is not without its challenges in terms of being able to have constant supply chains and keep people on board and so on. So it's not quite as easy. It makes it sound so simple that, well, you just have to give an intravenous injection, but it's not quite so simple within 3 hours, because there's some evidence, I think, I mean, correct me if I'm wrong, but when I read your papers, I think there's some evidence that if you wait too long, it may increase slightly the chances of some of the thrombotic complications. So, if you give it too late, perhaps you do increase some of those things. After all, plasmin is there for a reason to some extent.
Well, you wouldn't give it late.
Yes, so that's right. So I think there would be a group of people who might not, probably quite a big group, who aren't yet. It's more than just the cost of having the drug and someone to give it. It's building the whole infrastructure to do that, which is a direction that I hope that we're heading, because I hope that health systems are being strengthened, and certainly that's part of UNAIDS' wish list. It's something that we're involved in somewhat, and we have to see where it fits. So I mean, those are just a couple of sort of comments, and I don't know if you want to. Well, they're comments rather than questions, but if you want to comment, and then we'll pass over to the other side.
In terms of health...
Can I have one question? Because it was clear from your presentation whether it's a heat-stable product.
Yes, it is a heat-stable product. There's, you can boil it, if you like, and it's heat-stable. You can freeze it, but the vials crack at low temperatures. So it's very heat stable. So there's no cold chain issues at all. In terms of health services, I don't know, I think about 7,000 or 6,000 of the patients came from Africa. So that hospital that I was in, the one that serves this community in Ibadan, they did the trial, so they had the patients, so it wasn't too complicated for them. So we recruited 20,000 patients, I think 7,000 from Africa, 7,000 from Latin America. They were just pretty ordinary hospitals.
And more people are, of course, living in urban areas, but most people that we deal with in the HIV world never get near a hospital, we hope. I mean, they're at much more peripheral levels than hospitals, and many of those in situations where intravenous infusion would be quite a major deal to establish.
Oh yeah, I think if you're in in the outback, that would be difficult, but lots and lots and lots of patients front up in urban hospitals like this every day.
Let's move on, and I mean, we tried to bring it together, and I think that the focus was sort of on, once one's got evidence, then how do things, what are the steps that follow, and so perhaps, Etienne, would you like to make a few comments and see where we get to?
Sure, thanks very much, Peter, and let me first of all thank you for organizing this event, bringing us over from the other side of the garden, and thank Jan for having come over from the other side of the lake, and bringing to us what is really a very important study. I'm director for a department that deals with violence and injury prevention and disability in WHO. So we are part of those people who try to increase interest in preventing trauma deaths. And most of our focus is on prevention, so addressing the root causes, but the response for those who have been injured is of course also very, very important. So we have supported this trial from the beginning, the CRASH 2 trial, and we're very happy when the report came out showing the results. So I basically have 3 quick points. Some of it was just covered a little bit by Peter. One is, I think that this study brings us a very great opportunity with, at the same time, a challenge is what do we do? How do we put this now into practice? And how do we decide that one study is enough science to recommend this drug around the world? When do we have enough? It's a discussion I've had with Jan before. Certainly we, from our department and from WHO, are looking at it very positively, and we believe we need to do something with this study, we need to promote the results, we need to have people look at it. And we were delighted to see that the British military, the American military, and President Obama himself now are looking at it too, because the more, I think, additional information we have about similar results, the stronger the evidence gets. And as you know, WHO has been criticized for many, many years ago not having proper processes to recommend the use of a drug. We now have a whole set of steps to be taken, and we will go through that and have our guideline review committee, as it's called, look at this so that there can be an informed decision on how much we can recommend this. But I certainly hope we will be able to do so. I do think, though, that there's two things we need to consider. One is the one Peter just brought up briefly, which is this time boundness, if that's a word. The fact that if tranexamic acid is administered in less than 3 hour time, it has much better results than after that. And that's important because, yes, a lot of the cases treated or observed in the study were in lower income countries, but a lot of people in those low income countries never made it to the hospital or arrived probably quite late. We know now that in most cities, people in 1 or maximum 2 hours after a severe injury will get to a hospital. That's even in the poorest countries. However, in rural areas, somebody in a bus crash in rural Peru or in rural Mozambique is not likely to get to the hospital in a short period of time, and it will take several hours, often many more than 3 hours to get there. So some of the positive results in addressing all severe bleeding patients should be looked at maybe a little bit more for that time issue. And then final comment is that, yes, we need to look at the results of the CRASH-2 trial. We need to promote tranexamic acid, but it cannot be done in isolation. We have a lot of work to do in improving trauma care systems in general. If there is no unique telephone number to call, like the 112 we have in Europe or 911 in the US, if there is no ambulance that can get out there to a car crash or a bullet wound or whatever, if there is no trained personnel who knows what to do in case of a severe crash and how to respond, if there's no basically equipped hospital to go to, if all of these issues are not addressed also while we promote the use of this medicine, we probably run the risk of losing a lot of its potential impact because of all of these other factors. So strengthening healthcare systems is certainly very important, and looking at particularly the trauma care component of that is very important to us. This is why we, at the last World Health Assembly, launched the GACI, the Global Alliance for Care of the Injured, which is an alliance bringing together lots of professional associations, lots of experts, lots of governments who want to work together in promoting and improving trauma care systems. We have a number of projects going on. We have a trauma care checklist, which will be a basic checklist for people who receive severely injured patients in their hospital to go through to see that they don't forget. And we have included TXA in that tranexamic acid in that list. We're providing guidance to countries, and we're considering even to start working on a new project, which would be to look at uniformizing all these different emergency telephone numbers that exist in the world. Right now, there's more than 120 unique telephone numbers around the world to call to, and as we travel more and more, you probably, and I usually don't know which number to call if I meet a car crash when I'm traveling to whatever country I'm in. So that's also part of the things we're considering. But so basically, from our side, we're really pleased with first of all, the fantastic work done on this study and the results that came out. And we're certainly keen to continue collaborating on taking the next steps in promoting it around the world. Thanks.
And Chris, do you want to give the sort of essential medicines view, and then we can perhaps have a general discussion about where we go and what comes next?
Right, I'll go very quickly. Can you see me from there? Should I move to the middle? Huh?
It's fine.
It's fine, okay. Isn't this what? Yeah, okay. A fairly brief presentation, but it has two components, the global and the local. The local from the country I know best, mine, Sri Lanka, because when this presentation was coming on, I actually did check with some of them and got some of these things. But to start off on tranexamic acid in the WHO model list of essential medicines, first of all, very quickly, what are essential medicines? And therefore, I'm preaching probably to half of the converted and to convert the other half. It is a limited range of carefully selected essential medicines, leads to better health care, better drug management, and lower costs. Definition of essential medicines. Essential medicines are those that satisfy the priority health care needs of the population. 10.7% deaths in the 20 to 49 age group would clearly come into the priority health care needs of the population there, right? Selection of essential medicines, selected with due regard to disease prevalence, evidence on efficacy and safety, and comparative cost effectiveness. Clearly, it's not what we call eminence-based opinion, but it is an evidence-based opinion, and we keep on saying we need the evidence to make decisions on that. We need to have continuity and sustainability on essential medicines. Well, that is one of the few things that we have actually done consistently for a long time in WHO. The first list was in 1977. We are now on the 18th list, revised every 2 years. It would be difficult to find a WHO program that has done this consistently. And that is something, in a sense, our flagship, and we continue to focus on that and put it out. And at the moment, we have 374 medicines in the 18th list, which was put out in April 2013. So that's what it is. Yes, we have the WHO model list of essential medicines. You can just see what it means there. And we have the latest list in April 2013. What do countries do? Well, over 100 countries have national essential medicines lists based on the WHO EML. It's actually much more than that, but because we haven't got an updated list of countries, we keep it at 100. So if you go and look at the countries, and these lists are available on the website, in the WHO Essential Medicines website, you will see there are lists of these essential medicines that they have got. When revising national lists, medicines on the WHO list will be taken into account, because then the countries have a look at it and say, well, this is what WHO thinks it is useful. Is it useful for our countries? Yes, in this particular one, this is useful. We may consider that. This, no, it's not useful to us. This is for malaria. We don't have malaria in our country. Cross it out. Okay, fine. Leishmaniasis, no, we don't have it. Cross it out. Okay? And that's sort of, how many other countries will do that. This is important for multilateral agencies. The World Bank, GFATM, all of them sort of look to the national list or the WHO list to see whether the medicine that is being requested is in that list. In a sense, it's a certificate of good housekeeping sort of thing, because this means that this medicine has gone through and then been approved. And so if it is available on that list, or it is actually listed on that, in most situations, if you go to a funder and say, we need this medicine, and it's on your national essential medicines list, there isn't any more question about whether it's required in the country. There may be further negotiations on price and whatnot, but it's taken as a given that if it is on the national essential medicines list, then it would be useful for the country. Donations of medicines. Is the medicine on the national list? In a sense, this has been a fairly good cover to prevent unnecessary medicines being, in a negative way, to prevent unnecessary medicines being dumped on the country, and in a positive way, saying these are the medicines that we want. However, it is the final statement that is important. The list is a model. It is not an absolute list. It is an example for the countries to have a look at and then decide what they want on it. And you can certainly see that the countries make their own decisions and have their own medicines which they think are useful. Unfortunately, sometimes we have problems because the country will come to us and say, we have made our essential medicines list and there are 530 on it. And we sort of ask them, don't you think that's a bit too much? And they say, no, no, we need all these medicines. And then we tell them, but the WHO list for the whole world has only 374, which brings forward a rather awkward pause after that. But nevertheless, what we now realize is it's 530 there because it's industry realizing the importance of the list and pushing their medicine in. And in that particular selection, those medicines have come into the list because that means an approval for purchasing. So you can see how the influences do come in. Go on very specifically to tranexamic acid and essential medicines. The 18th expert committee, 17th list in 2011. Here is the statement where we clearly said, section 10, addition of tranexamic acid injection for the treatment of adult patients with trauma and significant risk of ongoing hemorrhage. On basis of the results of a very large trial. We just got one trial only. Generally, we ask for, multitude of trials, but the CRASH-2 trial with 20,000 patients was simply more than sufficient. Tranexamic acid specifically for trauma patients, including those who have been in road traffic accidents. The committee concluded that there is sufficient evidence to support the proposal that listing tranexamic acid may contribute to a reduction to this cause of death. So we got it in 2011. Now the question is, so how many countries have incorporated into their national list? Unfortunately, very little. But then on the other hand, it may be an unfair question to ask because it's only in 2011. Countries sometimes do not regularly update their list, and so it may be not have enough time to go in. Has it increased? And I mean, when we try to look at the list, we find that it doesn't figure prominently in the new applications. We in WHO, when we go for country meetings, have tried to advocate for that and to get it in. That's at the moment that we have. Now, my question is, after looking at this, I thought, okay, I come from Sri Lanka. Sri Lanka contributed 103 patients to the CRASH-2 trial. So that means there was an investigator in Sri Lanka itself who knew this trial and would therefore encourage it. You may know him, Dr. Ellavela, I spoke to him. So then I said, first of all, is this product available in the country? I went to the medical supplies department, I wrote to them. 6 products of tranexamic acid are available in the country. So it's not a question of availability. The only thing was most of them were coming as 500 milligrams in 5 milliliters. So it wasn't the sort of standard one, but they were still available. Then I asked the medical supplies department, which is the government supplies department, can you give me a breakdown of how much use there has been in tranexamic acid? There's a slow increasing uptake, but not very much. Then they gave me a breakdown of the countries, of the hospitals that were using it. And you could see that the major hospitals were using it to a great degree. And I thought, oh, that's good. But when I asked them, they said, those major hospitals have cardiac units, neurosurgery units, and it is those people who are using it. If you went to the district hospitals with trauma, there wasn't that much of use. So then I went and asked the person who did the trial for Sri Lanka, what do you think, why is it that people are not using this? Is there a problem with the 3 hours? He said, no, I don't think so. I think it's simply a bit of inertia and a lack of, a bit of apathy. And there is no specific protocol which says this is what you must give. And that may be the situation where we need to look at whether there is a specific protocol or not. Ironically, the country is small and has a reasonably developed healthcare system, and most patients with trauma would be brought to the hospital within 1.5 to 2 hours. So everything, in a sense, exists there. It's a question of changing the practice. And that is the issue that I have. I mean, how do we go ahead and change the practice? Getting it into the essential medicines list of Sri Lanka wouldn't be too difficult. But if they are still not going to use it, this is the issue. Do we have the question of going to do advocacy in each of the areas and talking to the accident and emergency people there? Is that what we got to do? I don't know. I mean, I was just thinking about that. And there is one specific question that I'd like to ask Ian. When you started this trial, was there any hesitation by the surgeons in doing this? Did they say, we don't know, or they were not very sure? Or they said, okay, let's do it, or was there some hesitation on this one?
There was no it was the easiest trial. The steroids in head injury trial was a difficult trial to do because half the world believed in it and half the world did not believe in it. Nobody was in the middle. But with tranexamic acid in trauma, it was easy, very easy. They all thought there was a good reason to think it should work, but but they didn't use it, and so we didn't have any problems. I think you hit the nail on the head. You know, it's an effective treatment. It's in the list. It's just nobody's told A&E doctors about it. Nobody's told them, and they just don't know. They don't read the Lancet. You know, it doesn't. It's the simplest things haven't been done, and you know it just needs a political will to do it. I don't think we need to depend on the wholesale upgrading of the trauma care system. I really disagree with that. You know, we don't need. You know, they didn't have ambulances in Africa when the 7,000 patients were randomized. They were brought in the back of cars and the back of carts, but they were treated within 3 hours, lots of them, and the treatment was effective. So, you know, the treatment was effective in the health system that exists. You know, if anything, you know, we could use the fact that this is an effective intervention and say, well, look, now we need a health system to provide it. But it's not the other way around. We don't need a health system, and then once we've got that, we can provide this effective treatment. It's the other way around. You find an effective treatment, and that gives you a reason for having a for having a trauma care system. You know, very little else has ever been shown to be effective. In fact, you know, one of the last things that was in WHO guidance actually was the use of colloids for resuscitation of trauma patients. Well, one of the most common colloids was just banned by the European Medicines Agency because it increased the risk of renal failure and increased the risk of death. You know, so lots of things in trauma we don't know what to do, but we do know this. And this thing about having many trials, that's a hangover from the old days when people used to do a little single center study. Single center studies are unreliable, and so regulators used to ask if there'd been a single center study, they'd ask for another center to do another single center study, and if they both pointed in the same direction, they would agree. But that's a hang-up for the old days. You know, that you can consider the CRASH 2 trial as a meta-analysis of the same trial in 40 countries. And the results go through the data like like the word Brighton in a stick of rock. You know, it's everywhere. It's all the same. So I don't think it's because of lack of evidence. It's just political will. We haven't done anything.
Thoughts? I mean, I think one of the things that, you know, that keeps coming back to me is that there's the role of the essential medicines, and, you know, and Tranexamic is there on the essential medicine list, and that allows countries to adopt it on their national lists if they want. And then WHO also has, as was mentioned, its new processes, also stimulated somewhat by the Lancet and Richard Horton's attack on WHO some years back for the way that it produces recommendations and the formerly rather unevidence-based approach. So WHO now has the Guidelines Review Committee that Chris knows well and is part of. And the Guidelines Review Committee of WHO was brought in response to this criticism that, well, you know, WHO just issues lots of guidelines and recommendations without really assessing without a formal process, and in particular without transparency about the process as to how decisions are made. Now, that's a very good thing that WHO's recommendations now are much more transparent and are much more based on the evidence. It does, of course, come at a transaction cost, that there's a sort of quite a heavy process now for synthesizing the evidence, whereas actually we know that the evidence on trauma is essentially the CRASH 2 trial. So despite the fact that you'd have to get somebody to go and bring it all together, we know more or less what they're going to find. Synthesizing the evidence so that you can see the limitations and the pros and cons of the evidence, synthesizing the so-called preferences and values, which is, you know, how good a thing is this for people, for clinicians, what do they think about it? So the slightly sort of softer things, and those are put together into recommendations, much as many other bodies are making recommendations, and there are two approaches more or less. One is a full recommendation from WHO that either full or conditional that this should be done or it should be done in certain settings, or WHO also issues what's known as rapid advice, which is where something has come out that's a lighter process and where something has come out and there's new evidence around, so that, for instance, in the HIV field, we use antiretrovirals for treating people. We also now have trials that show that antiretrovirals prevent people who are HIV negative from catching HIV, pre-exposure prophylaxis or PrEP. So WHO put together some of that evidence, and the Guidelines Review Committee agreed to let it go through a rapid advice process, such that WHO, quite soon after the first trial of a single trial, the IPREX study, came out, they were able to issue rapid advice. And I don't know the extent to which countries like Sri Lanka and others would listen to that advice either, but it seems to me that it complements the essential medicine lists, because then it sort of, not only is it available in pharmacies and it's on our essential medicine list, but somewhere we've got WHO up there recommending it. And again, those recommendations are also for adaptation and adoption in a very similar way to the EML. And of course, it comes back slightly to the question in your presentation, Ian. You talked about the sort of the siloification. And that's a bad thing, but it has the huge advantage that when the TB programmers want to say, well, it's time that you started using pyrazinamide twice a week instead of every day, they can take it through a process and they know who they're talking to. And there's a national program manager for TB who's familiar with the TB drugs. And when WHO invites him to the annual meeting of TB program managers that happens once a year in Paris in 2 weeks' time, they'll all be sitting there. And if WHO wants to say, you know, things are changing and the way we're going with TB is this, it makes it so much easier to get TB programs and TB patients dotted around the world to get whatever new treatment is coming down the line. Once we stop siloification, which is an interesting word, and we get rid of a few of these silos, that's clearly a good thing for sort of joined up healthcare, but it actually becomes less easy to see how you press a button and make something happen. We have the same thing in HIV, that the WHO guidelines on ARVs, we sort of know who the target audience is to try to get those implemented, because there are national HIV program managers who are responsible ultimately for the treatment and deciding what drugs are given, even to the person who's living in a village over there as well as in the city here. And so I see a sort of quite an interesting discussion around it's the sort of diagonal, horizontal, vertical discussion which we're trying to go beyond. Certainly in UNAIDS, we talk about out of isolation and building wider systems. But I think that's also a challenge for how things. I mean, would you agree with that, Chris, in terms of how we move forward to get tranexamic acid more widely used?
I was checking is whether there is some international trauma protocols. Because you can't expect these countries, I mean, just like the WHO model essential medicines list, the countries sort of say, yes, we have to adapt it and do all that. But they simply take this and, sort of the expertise isn't there, so they cut it up and then, get a reasonable list like that. In a sense, if we give them an international trauma protocol to the countries, whether we have something like that, and then tell them to adapt it, that might be sort of, one way. And in that clearly would be tranexamic acid. I mean, the logical constituency I would see is the International Association of Trauma Surgeons or something like that, because when we tried to do something for children's medicines, we went to the International Federation of Pediatricians and got through them. So in the same way, that may be one thing that we may need to look at to see whether we could get it. That's the question.
What are the routes for that?
Yeah.
We don't really have such a thing in our program. I mean, it's an emerging program that is struggling a lot in terms of resource, so we don't have such a thing. There are international associations we could talk to, and they are members also of the Global Alliance, and we have sensitized, even Jan has sent one of his colleagues, I think, to talk to them in some of our meetings. So there is some work going on in that direction, but not yet formalized, I think.
Carusa, last comment from the floor, and then we'll have a brief wrap-up.
Thanks very much. My sense, though, is that a lot of the recommendations that come up because of very strong marketing by the pharmaceutical industry. And I'm wondering what the liaison is on this with them. That's one question. And the second thing, I was actually listening to Dr. Etienne Krug talk about this, and I said, well, we at UNAIDS, I'm sure WHO and others, get this kit, this travel kit to take around the world, so if you have an accident, you can, is this thing in there?
I don't know, but I don't think it's in the kit, because that's 1,000 milliliters that you've got to take, and that's not easy to take. I don't think you have any fluids whatsoever in our emergency kit.
It's like 10 mils.
Mm-hmm. Oh, okay.
It's not 1,000.
Okay, it's 10 mils to be put into 1,000.
Yeah. You can do anything. You can put it into a bag and infuse it. You can put it in a syringe and inject it. It's just 10 mils, and it's in terms of pharmaceutical industry, it's a generic drug. Pfizer originally had the license. I'm trying to get them to apply to get FDA approval, but it's difficult because they think that the companies can't really be bothered with drugs like where they don't make a lot of money out of it. But I'm getting slow progress there in terms of getting them to, because in a way, if I want someone to make money out of it, and so then they'll have a vested interest to tell people about it. So there's a company called Hilton Pharmaceuticals. It supplies a lot of sub-Saharan Africa. I met with the head offices in Karachi. I met with the chief executive of them. It's strange. I was in a meeting with the chief executive of a pharmaceutical company. I was trying to think how I could get him to make more money. But if only. But yeah.
Well, I think we should wrap up. I mean, I think that the reason for bringing us all together was to see this as something of a case study for us to think about, the process. It's not just a case study, it's a specific case, and it's clear. I think nobody's disputing the basis of the evidence. Here is a cheap intravenous product that can save lives, that it would be great if it was much more widely used. I think, that's certainly my reading of this as I see it. And I think I can certainly imagine, as a researcher myself, I can imagine your frustration, Ian, in sort of seeing how there is an inertia about the system to get out there and save lives. And that's something certainly that we're very familiar with in UNAIDS as well, the sort of the process that takes time. I think that we understand some of the routes that one can try and push that forward. I think people need evidence from a variety of sources, and bringing that together from the military, from the trial study, from operational studies on the ground that say, look, here it's working. are some of the, the things that are being brought together that you have done. There are clearly some big, some milestones along the route to success. The fact that it's appearing on EMLs, the fact that it appears on the trauma checklist, the fact that, that consensus is building around it, and I'm sure the fact that President Obama carries it in his toolkit are all sort of good things for the process. I think that I certainly don't want to preempt the discussion by sort of pushing Etienne and Chris along a particular line, but I think that clearly WHO's Guidelines Review Committee at some stage has to take a view on whether they're at a stage where there is now sufficient evidence and sufficient resource within WHO to sort of prioritize this as opposed to a new malarial net or a new this or new that, because there's only a certain amount of meetings that they can bring together, and et cetera, et cetera. And I'm not going to take a sort of a line on that, but it's clear that some of the feed into that is happening. So I think to me, that's quite optimistic, and we can look to trying to go there. I'd like to thank the small number of audience that we've had here in Geneva for coming, and I hope you found it of some interest. It's not mainstream for HIV, and it's not, it's not enough mainstream for any of us, which is perhaps why it's a good thing to have the meeting. I hope that we've got one or two people listening around the world and in offices and so on. So thank you for joining us. Ian, thank you very much for coming over from London to talk to us. And Etienne and Chris, thanks very much for what's been an interesting hour and a half. Thanks.